Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. In this podcast, we talk with Dr Angela Cadogan around the assessment of sternoclavicular joint. She outlines for us some of the anatomy of the joint and then how she conducts her sternoclavicular joint assessment. We chatted for so long in this podcast that I've split it into two sections. So this session will cover the assessment of the sternoclavicular joint. Enjoy. Hey, welcome to Glenohumeral Gurus for our second podcast with Dr. Angela Cadogan. Angela, it's so great to have you back to discuss all things sternoclavicular. So welcome.
Thanks very much, Margie. It's really good to be back.
Yeah, cool. Hey, so last time I know that I rushed in with my general excitement. Do you want to just share with people your background and how you get to be talking with sternoclavicular joints with me today?
Sure, thanks. Well, my current role, I have a couple of current roles probably that relate to the sternoclavicular joint. So I'm a registered specialist physiotherapist in New Zealand. So I work in private practice doing clinical consultancy for people with shoulder pain. And probably the other role more relevant to sternoclavicular joint is I work in an orthopedic triage role in the public hospital here in Christchurch as well. And that, as you'll probably hear as we go through the podcast, quite a few of the non-traumatic sternoclavicular joint conditions get referred through that public hospital pathway. So I see probably more the acute traumatic ones in private and the more atraumatic ones in the public sector. So those are my main roles now. Special interest in shoulder actually evolved out of the throwing shoulder in sports physio, and I still see quite a few sports related shoulder pain patients on a consultancy basis, and that's sort of where my interest grew. But yes, it sort of went down a diagnostic path with my PhD, and here I am.
Here you are, yeah. And we had a great podcast with Ange talking about AC joints, which is how we kind of got chatting about sternoclavicular joints, because as we were morphing through that discussion, we were like, oh no, we should do that properly in a different discussion. So it's such a challenging joint, isn't it? Because I think it's so well, there's lots of different factors around that. I mean, I think around all the different muscle attachments and how they work, because as a clinician, what else how am I going to affect change in that joint, I guess? If you think, then if we step through, my plan for today is to talk around sternoclavicular joints in detail, maybe discuss some of the anatomy around that to start with. If we talk then around the assessment of sternoclavicular joints, your differential diagnosis as well, I'm really interested in, and whether people, because I know you mentioned in the AC joint talk that you felt like people were missing AC joints. Do you really think that people are also missing sternoclavicular joints, perhaps for different reasons? And then treatment and what it is that you do and what you think clinicians should do, and any other little gems you have. I really enjoyed our last talk about just exchanging ideas and sharing information. I think is great, and I know that people will enjoy our discussions. So if we start with the anatomy, obviously, what can you share with me around that?
Yeah, well, the sternoclavicular joint, again, lots of similarities to the AC joint, just in the sense that it is a pretty small joint, but and it's a synovial joint, so it is prone to a lot of the common conditions that synovial joints are prone to. But its probably main biomechanical function, if you like, is to really transmit force across that synovial joint through. It's got a little articular disc as well that sits within the joint itself, which is attached to the joint by ligaments. And it is prone mainly because of that biomechanical function, if you like, that force transmission. It is prone to trauma and
Yeah.
also a range of non-traumatic conditions. So I guess as far as the anatomy is concerned, it's got very thick, very strong capsular ligaments around the
Mm.
joint. It's got the articular disc that we talked about attached by ligaments. It's also got, if we make the analogy with the AC joint with the corticoclavicular ligaments, it's got a similar set of ligaments, the costoclavicular ligaments, so more at the medial end. So that's sort of the backup stability mechanism really for that sternoclavicular joint, that if the ligamentous, the capsular ligaments are injured, then that costoclavicular ligament does afford it a little bit of stability. So yeah, very strong joint. Force transmission is its main job. The only attachment of really that whole shoulder girdle to the skeleton. So there is a huge amount of force that does go through that joint as well. So yeah, it's very interesting.
Yeah, yeah. And so when it comes to making an assessment of somebody, how do you go about that if you think that that's involved?
Yeah, well, that's interesting. And I think you mentioned before how we talked in the AC joint podcast about the AC joint often being missed.
Mm-hmm.
And I probably find even more so with the sternoclavicular joint, firstly, because it's not as common, so it's more rare anyway. So you're tending not to see as many of them in clinical practice. But we also talked about the AC joint being the great pretender. I often think the sternoclavicular joint is even more of a pretender, because unless you've had a clear history of trauma, and it's pretty obvious, if the sternoclavicular joint's been affected by trauma, if it's, dislocated, or it's often painful quite locally. But the more chronic sternoclavicular joint instabilities, but also the non-traumatic conditions, the pain location is hugely variable, and very, very rarely do they ever point to that sternoclavicular joint and just say, that's my pain. It's pain can radiate actually quite commonly straight through posteriorly from the sternoclavicular joint. So people often come in and they say, they're pointing to their scapula over that posterior shoulder area and saying, it's just aching, it's just this nagging ache, it's just this toothache, it won't go away. And you can almost draw a direct line through from the sternoclavicular joint posteriorly. So pain referral pattern directly posteriorly is quite common, but also they tend to get a lot of pain anywhere in that kind of supraclavicular triangle. So if you draw a line sort of from your clavicle and then up your upper trapezius, even behind the ear, up to the mastoid process, along the side of the jaw, and even down the front of the neck, all in that triangle, some people even down into the axilla. And a lot of them will describe it just as a toothache. It's just a constant nagging ache that they just can't get away from. And so a lot of, when you say, what am I looking for the sternoclavicular joint? Often I'm not looking for it necessarily, but what I'm seeing, especially in clinical practice, is a lot of patients who, because of that distracting pain location or quite remote from its source, they've had a lot of treatment around the cervical spine, the TMJ, the AC joint, the shoulder, you name it, they've had it, and they've had no luck, no joy, and relief of symptoms. So to me, that history of that widespread pain distribution and the fact they've had a lot of other treatment for a lot of other things is actually helpful for me, because I can see what has already been addressed and not been helpful. And then that does help to narrow down my suspicion, if you like, that potentially this could be a sternoclavicular joint problem. But yeah, and in terms of assessment, it's certainly the history, again, whether there's trauma or no trauma. The traumatic ones, often it's you see them quite commonly in sport, collision sports especially, or tackle type sports, where they either the shoulders are forced backwards or forwards, and that can lead to sort of an instability of the SC joint. They land on their side, or they're sandwich tackled, so they're sort of that concertina mechanism. So that can cause an SC joint instability, or they have a direct blow onto the sternoclavicular joint region, which can lead to a subluxation or dislocation as well. So history, pain location, associated symptoms, because I think if we look back at our anatomy again, if you look at some of the things that sit in behind that sternoclavicular joint. So you've got a lot of pretty important stuff sitting in
Yeah.
there. So you've got a lot of neurovascular structures. You've got your common carotid artery, you've got your internal jugular vein, you've got your superior vena cava, the subclavian artery and vein, phrenic nerve, vagus nerve, brachial plexus, trachea and esophagus. So there's quite a lot of stuff that sits in behind there that, you really need to be mindful of the symptoms associated with that. So any arterial or venous symptoms in the upper limb. So that would be arterial, meaning, hand goes white. Venous, meaning maybe it goes blue and gets swollen. Any neurologic symptoms down the arm, the mediastinal symptoms, so the tracheal and esophagus, the common ones there would be relating to the trachea particularly. They might report shortness of breath, sometimes a lot of coughing, what we call dysphonia, so that's sort of a hoarse voice where the voice and the larynx is kind of being affected there. And esophageal symptoms, difficulty swallowing or choking food. And quite often, especially if a patient takes medication, they'll say, I'm choking on my pills, or I can't swallow my pills. Something feels like it's getting stuck. Now, usually that's a sign that either the sternoclavicular joint is posteriorly dislocated, which is a medical emergency for those reasons,
Yeah.
or they've got some non-traumatic condition which has increased the size of that joint to the point where it is putting pressure on those structures in behind it. So questioning the patient specifically about those associated symptoms, the neurovascular symptoms and the mediastinal symptoms, is also really important. And they'll also, in terms of aggravating factors, the things that people with sternoclavicular joint problems do not like, they don't like full elevation of the arm. They don't like carrying heavy things down beside them with the arms straight by the body. They tend not to like lying on their side because that does, put the joint in a very compressed or unstable position. And they generally don't like weight bearing through the upper limb either. So, a fall on an outstretched arm is actually another mechanism of injury. So those are all the things I'm sort of listening for in the history and the symptoms and the behavior of the sternoclavicular joint. The other thing that you really want to get into as well, if it's a non-traumatic presentation, is their medical history, because there are quite a few conditions that can manifest around the sternoclavicular joint. It's a bit of a minefield of red flags too, that sternoclavicular joint. So things like infection, and that can be anyone who's sort of immunocompromised, anyone who has had a recent infection, recent invasive procedure, sort of an injection or surgery, even lifestyle factors, so IV drug users or anyone who has to sort of inject for any reason regularly. So infection is certainly something you'd be questioning about. Neoplasm, so primary sarcomas around the sternoclavicular joint, and they're quite common. Squamous cell carcinomas and lymphomas, I think, are also quite common for primary tumors around the sternoclavicular, but also primary tumors, but the secondary ones are more the squamous cell and the lymphoma. So anyone with a history of those, you should also be thinking along those lines with the sternoclavicular joint. Rheumatoid disease, so if they have rheumatoid arthritis, it can be affected as part of that. The seronegative spondyloarthropathies, so the axial spondyloarthropathies, psoriatic arthritis, and that tends to affect not the bones, but also the entheses, and that tends to be the younger men who will present with that. So those seronegative. And there's also crystal deposition disease. So that's CPPD, which is a bit like gout. It's actually called pseudo gout, but instead of depositing urate or uric crystals in the joint, it's more calcium pyrophosphate crystals. So that can also affect that sternoclavicular joint. So you do really want to do a good, thorough health history or medical history for the patients who present with those non-traumatic SC joint conditions as well.
Yeah. So, I mean, I guess what I'm hearing is the traumatic ones are not so, well, some of them are medical emergencies, aren't they? Do you know? That's absolutely. But from what, and my impression was that was an acute on the sports field thing. But you think you see these people posteriorly dislocated down the line as well? Is that, you know?
No, not necessarily, no. So the posterior dislocations do tend to be more traumatic. So those are the ones that you're
Mhm.
more likely to see sort of on the sports field, or motor vehicle accidents, car
Yes.
crashes, maybe
Yes.
cycle accidents as well. So it's got to be pretty high force trauma really to dislocate that sternoclavicular joint posteriorly. But I guess if you're asking that in relation to some of those mediastinal symptoms,
Yes.
yeah, if you've got something like osteoarthritis in that
Mhm.
sternoclavicular joint, or there's another condition called condensing osteitis, I think, which is where, for unknown reasons, the medial end of the clavicle just starts to, there's just a lot of hyperostosis and it just gets bigger and bigger and bigger. So just the size of the degenerative joint or that
Okay.
hyperostotic joint can actually just put that pressure on those mediastinal structures,
Which
which
is more of
seems,
a slow progression, but
yes,
they would still then present with the, the tracheal or esophageal symptoms. That's what
definitely,
you're
yeah.
saying.
So it
Yeah.
comes on very gradually over a longer period of time, and not so much a medical emergency. It certainly needs to be investigated, but yeah, not as a medical emergency as you would with
Yeah.
the traumatic
The
ones.
traumatic ones.
Yeah.
It's interesting, isn't it? Because some of these are sort of a differential diagnosis that then isn't sternoclavicular joint. And from what I'm hearing from you, some of these things are actually then as a consequence of your sternoclavicular joint problem, in that
That's
you would
right.
present with this problem, your sternoclavicular joint, and then have you these other symptoms. Hey,
Yes, that's it. Yeah, yeah.
yeah. And so you're leading that mainly then with your subjective history, really looking to rule out those red flags and to then gain a better understanding, medical history, obviously, but then how there are other aggravating and easing factors. That's how you would, yeah.
Yeah,
Is there
definitely in the
anything
history.
objectively that clinicians should be doing too? Here I am shrugging my shoulders. Some of
Yeah,
people who are listening in the car.
absolutely. Yeah. So objectively, probably one of the big things actually is look at the sternoclavicular joint. And if it looks thickened or swollen compared to the other one, that's actually quite specific when you're looking at diagnostic accuracy. That's quite specific
Okay.
for painful sternoclavicular joint conditions.
Yeah.
So definitely look at it. Um, the other thing, I guess, and this is where it's similar, if you think of its biomechanical function, it's the other end of the AC joint.
Mm,
So what the AC
mm,
joint, when that's moving, the sternoclavicular joint will also be moving. So similar aggravating movements for the SC joint, full elevation, definitely. And
yeah.
there's quite a lot of movement at that sternoclavicular joint, and probably I think about 35 degrees of movement when you elevate your arm. So it is a provocative position for that SC joint. Adduction can also be painful. Hand behind back can also be painful.
Yeah.
Also, I can't remember if we talked about it in the AC joint podcast, but scapular physiologic movements. So actually just shrugging the shoulders. So shrug, depression, protraction, and retraction, because
Mm,
both of them, or all of those movements, do move that sternoclavicular joint. So if any of those are painful or
mm,
reproducing the patient's symptoms, then that would add weight to it potentially being a sternoclavicular joint problem. Palpation. Interestingly, I mean, I use palpation a lot. I always compare it with the other side because they
yeah, me
can be
too.
a little bit tender anyway.
Yes.
But interestingly, if you look at the diagnostic accuracy, palpation pain is more sensitive. So it's almost, if it's
Mm,
not painful, you can rule it out, rather than if it is
that
painful, you can rule
is,
it in. So
yeah.
yeah, so that's quite interesting there as well. But yeah, those would be the main features. When I'm really digging, if I'm
Mm,
still not sure, I will also, because of the muscle attachment of sternomastoid to that medial clavicle, Sometimes if you resist a sternomastoid contraction, you can also reproduce pain at that sternoclavicular joint. So you would side flex and rotate the head and then just resist that rotation for sternomastoid. And it might also reproduce, if it's a particularly irritable joint, you may get some pain reproduction with that one as well. As far as I'm aware, there's no special tests for the sternoclavicular joint. So if anyone
It's
knows of
okay,
any, let
isn't
me
it?
know.
I mean, as with lots of these things, the way that I think about it is the cluster of these things, isn't it? You know, when you have lots of, you know, these subjective findings and then objective findings that are consistent with either the mechanism or their history, it's about pulling all that picture together,
It
isn't
is,
it?
absolutely. Because I think if you look at shoulders and you say elevation or flexion of the arm aggravates it, well, that's every shoulder condition ever. You know,
Exactly.
it doesn't
Exactly.
really help you differentiate. So probably what I should have prefaced my assessment findings with is the fact that you've first ruled out everything else. So you make sure it's not the cervical spine causing all that
Yeah.
diffuse pain. You make sure they've got near enough full passive range of motion. In other words, they've got a frozen shoulder or a stiff shoulder condition. The rotator cuff is not overly painful or weak, which might be a rotator cuff condition. Then you're really starting to eliminate a lot of the really common things with the shoulder. You're not left with a lot else that it can be, and that's where the AC joint and the SC joint probability of those is higher once you have ruled out those other things. So you have to do all of your tests really for that reason. It's not something where I, even based on my subjective examination, I wouldn't only then go and test objectively for the sternoclavicular joint. I will still go through all of my usual standard, you know, passive range of motion, active range of motion, resisted tests for that reason. And the ones that I've outlined, you know, a few minutes ago, are the ones that I would tend to find are more provocative for those sternoclavicular joint problems.
Yeah, because I think I don't routinely assess, so I will routinely, like you say, I think I will, you know, active range of movement, resisted range of movement, passive range of movement. I don't routinely shrug into, you know, protraction, retraction type thing. But I guess if I was suspecting SC joint, then I'm much more likely to put that in my assessment than not.
Yeah, absolutely. Yeah. And actually retraction or pain with retraction is another one of the tests with very high specificity for the sternoclavicular joint as well. So I think it's over 80, it may even be over 90% specificity. So yeah, certainly retraction and is a specific test, as well as looking at that thickening and that swelling around the sternoclavicular joint. And it's interesting, in my job at the public hospital in the orthopedic triage department, and when I say triage, basically what we're doing is we're receiving the GP referrals. So we're not seeing the patient at that triage point. We've just got a piece of paper, and very, very often we'll get a patient referred with a lump on their medial clavicle. Please, could you advise or see this patient? And in many cases, we go through sort of an investigation process, but at the end of the day, once we've ruled out anything nasty, we go back to the GP and just say, are there any symptoms associated with this? Like, does the patient need clinical assessment? And they come back and say, no, there's no pain. It's just a lump, and they were worried about it. So it's quite interesting. We probably get, I don't know, maybe 2 or 3 of those a month come through in the triage system. So the lump, when I say look for the lump, don't just push the panic button on the sternoclavicular joint just on that basis, because they can be asymptomatic. It's just sometimes becomes a concern for the patient because they see this thing getting bigger and they don't know what it is, which is quite natural.
I hope you enjoyed this discussion on the assessment of sternoclavicular joint. Like I say, we chatted for so long. I've split this podcast into 2 sections. The next section will then talk about imaging of sternoclavicular joint and physiotherapy treatment options. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.